Hello friends, I'm Dr. Sindhu, MS Ophthalmology. I'm presently pursuing my senior residency from Sarojini Devi Eye Institute, Hyderabad, and I've done my post-graduation from the same. This channel is about brief lectures in ophthalmology, mainly targeting postgraduates and undergraduates. As you all know that our subject is very volatile. I've started this channel as a medium to impart my knowledge, whatever I've learned till date, in the hopes that you will find it useful. And you're very much welcome to give your feedback, and you can suggest me any changes or topics if you want to learn. So let's make learning fun. Today I'll talk about congenital glaucoma under these subheadings. Firstly, I'll introduce the topic, then classify the childhood glaucomas, go into the genetics, pathogenesis and clinical presentation, and then the UGA findings of anterior and posterior segment and related complications, and then the gonio findings, treatment, finally the differentials. So let's quickly get into the topic. Congenital glaucoma is a type of glaucoma in which high fluid pressure in your eye will damage the optic nerve, especially primary congenital glaucoma, which affects children between birth and 3 years, is a very serious condition that needs a lot of attention. It affects about 1 in every 10,000 infants, and untreated cases are a major cause of childhood blindness. Before heading into the topic, we'll look into the classification of childhood glaucomas. So childhood glaucomas are broadly divided into primary and secondary glaucomas. So secondary are the ones which are associated with any other ocular or systemic anomalies, whereas the word primary means the disease doesn't result from any other illness. So it is an isolated glaucoma, and the word congenital says that it is present since birth. So basically the primary is again divided into primary congenital. So primary is isolated glaucoma and congenital means it indicates that it is present since birth. So primary congenital glaucoma, also known as PCG, and the other primary glaucomas are juvenile glaucomas. First we'll look into the classification or furthermore subcategories of primary congenital glaucoma. So here there are newborn glaucomas, infantile glaucomas and late onset glaucomas. So this classification is based on the age of presentation. So newborns will present from 0 to 1 month. These are also known as true congenital glaucomas, and they constitute for about 40% of the cases. Whereas infantile glaucomas, which present from 1 month to 24 months, that is from 1 month to 2 years, they constitute for about 50% of the cases, and these are most common. Next is late onset glaucomas, more than 2 years, and these are rare, that is about 5%. So there are also spontaneously arrested cases in which there is evidence of past glaucoma, like herpes striae. We'll see what herpes striae is and what ophthalmus is. So these signs are present, but as such there is no IOP rise or optic disc cupping or corneal edema. So nothing as such is present, but herpes striae, ophthalmus are present. Now the genetics of this primary congenital glaucomas, if we look into the genetics, these are mostly sporadic, okay, and few cases are inherited through families. The mode of inheritance here is autosomal recessive, but the inherited forms are rare. They constitute for about 10%. Sporadic cases are 90%. Now juvenile cases, the age of presentation here is between 5 and 35 years, and the mode of inheritance here is autosomal dominant. So even the juvenile cases are less common. Primary congenital glaucoma cases are more common. So we are interested in primary congenital glaucomas here, which I am going to discuss in detail. Okay. Now the pathogenesis of congenital glaucomas, primary congenital glaucomas. So what happens? So we all know that this is our cornea, iris ciliary body, zonules and lens. So aqueous is produced in the posterior chamber and travels via the pupil into the anterior chamber and drains into the angle. One of the most important structures in the angle is a trabecular meshwork, right? So here in congenital glaucomas, in primary congenital glaucomas, there is this structure is at fault, the angle is at fault. There is trabeculodysgenesis, that is maldevelopment of neural crest cells which are responsible for trabecular meshwork formation. These are defective and the angle is not developed properly, due to which the drainage doesn't occur properly and there is impaired aqueous outflow, which will lead to an obvious increase in intraocular pressure. Here make a note that the iris may be flatly inserted, that is there could be a flat iris insertion or a concave iris insertion. So flat iris insertion is more common than concave iris insertion. So that is that indicates that the iris inserts flatly into the trabecular meshwork, okay, at the scleral spur or posterior to the scleral spur. So this anatomical predisposition will lead to furthermore effects. Now the presentation. Coming to the presentation, the baby is present at the age of 3 to 9 months, and if they present at birth, that is I am talking about the newborn glaucomas. Newborn or neonatal or true congenital glaucomas are more severe. Those are more severe forms. And they present with cloudiness and blue tinting of the eyes. Remember, this is the presentation. And in primary cases, there are no other ocular or systemic anomalies. That is, otherwise the child is healthy with or without a family history. That is, I told you that there are 10% of the cases which are inherited autosomal recessively. Those cases will have a family, they can have a family history. Now here, remember, there is no discharge and redness. So here, by this you can rule out certain conditions which we will see in the DDs. So the most important thing you have to remember is BPL, which is the classical triad of congenital glaucomas. So it stands for blepharospasm, photophobia and lacrimation. So lacrimation being the most common presentation, most common symptom, and photophobia is second most common. So photophobia occurs mainly due to corneal edema. We will see how that occurs. So before that we need to see what are the findings in the anterior segment. For that you need to go for an examination under general anesthesia, since these are infants. In the examination we will find out the following features. So it is established that the trabecular meshwork is at fault. There is clogged trabecular meshwork which will lead to a rise in IOP. So the entire eyeball is being very much pressurized. This rise in IOP will lead to corneal stretching. Here remember, neonatal eyeball is stretchable or distensible. This stretching will lead to an overall increase in size of the eyeball, that is ophthalmos or bullseye. So the eyeballs are very much enlarged. So this corneal stretching will now lead to endothelial break. Endothelial break, and there is an endothelial compromise. because of which you see loss of corneal transparency due to corneal edema. And it will give you an appearance of ground glass. So it is known as ground glass appearance, which is nothing but our corneal haze. Remember, this is the first or the earliest sign. This ground glass appearance will progress and it will lead to there will be a endothelial compromise, loss of transparency, and further leading to Descemet's tears. So these Descemet tears will appear as corneal opacified lines. Here you can see the corneal opacified lines which are horizontally oriented usually. So these horizontally oriented Descemet tears are known as HAP striae. Okay. Here make a note that if the breaks are vertically oriented, suspect birth trauma due to forceps delivery. HAP striae indicates congenital glaucoma. Clear, right? And subsequent increase in corneal edema and ground glass appearance and subsequent increase in corneal opacification will keep on occurring if you don't treat the case. Sometimes it will lead to permanent corneal scarring. Scarring can occur and vascularization also can occur. Okay, we will look into the complications. Okay. Now I will draw a picture of an enlarged eyeball. So this is your enlarged eyeball in a case of congenital glaucoma. Here we will go from anterior to posterior. What all complications are expected? I told you the cornea is enlarged or being stretched. This large cornea with a diameter of more than 12 mm is seen. It will further stretch with HAP striae and everything, and it will lead to astigmatism. Okay. This is number 1. Next is, along with the cornea, the sclera is also stretching. The entire eyeball is being stretched, right? The scleral stretching will lead to a thinned out. The sclera is completely thinned out and it will lead to bluish discoloration of the eyeball. So that is how the bluish discoloration is seen. Now there is also overall increase in axial length due to this stretching process. So because of this axial length increase, there will be occurrence of myopia, which can cause anisometropic amblyopia. Okay. Therefore, it is advised to perform cycloplegic refraction and retinoscopy if possible in such cases. Now, in this obviously there is deep AC. This deep AC because of accumulation of aqueous. So, retention of aqueous and deep AC is seen. This retention will lead to hydrophthalmos or acute hydrops. Okay. And then you can also see findings like iridodonesis, because there is a lot of pressure being accumulated, and iris atrophic patches in late stages because of constant rise in IOP. Okay, in late stages. And also the lens are anterior posteriorly flattened with backward subluxation. So these are all the anterior segment complications expected. Now we will go into the posterior segment. So posterior segment, because of the rise in IOP, the optic examination reveals asymmetry, and the cup disc ratio is more than 0.3:1 cup disc ratio, and cupping here is reversible. This is what you have to memorize. Remember, because the acute stretching will lead to rise in cup disc ratio. Once the IOP is normalized, once IOP is normal, cupping will regress. But whatever the functional damage had occurred might not revert back, but the cupping will regress. So remember that. Now these are kids, right? These are children. How will we measure IOP, corneal diameter, axial length and gonio in such cases? So the IOP measurement is done by handheld Perkins or tonopin. Remember, normal IOP in neonates or newborns is 10 to 12 mm, and it will increase to 14 mm by 7 to 8 years. Okay. Corneal diameter we can measure with a simple calipers, and axial length by ultrasound, that is B scan, and gonioscopy by Koppe's gonio lens. And what are the gonio findings here? So the whole problem is in the angle, right? So what are the gonio findings? We will see a anteriorly or flatly inserted iris, and there are few phenomenons which are confined to this congenital glaucoma, that is Loch Ness monster phenomenon and Lister's morning mist. Angle is actually devoid of vessels, right? But here root of vessels from major arterial circle are seen over the iris surface. That is known as Loch Ness monster phenomenon, and Lister's morning mist is nothing but the peripheral iris inserting into the trabecular meshwork will appear translucent. Here make a note that there is something called Barkan's membrane, which is a theoretical membrane, thin imperforate membrane covering the AC angle. So it is a theoretical membrane, and visualization of that in gonio is has not been definitively confirmed. So remember, there is something called Barkan's membrane, which is a theoretical membrane. Okay. Now coming to the treatment part, we will quickly get into the surgeries. Before that, I want to mention that medical management is not very effective, but we can give preoperative anti-glaucoma medications like beta blockers and prostaglandin analogs. Avoid brimonidine. So this is very important. Avoid brimonidine due to bradycardia, hypertension, hypothermia and apnea in infants. So these infants, right? So you have to avoid brimonidine. Okay. Now surgery is the treatment of choice here. Trabeculectomy and trabeculotomy is the treatment of choice in cloudy corneas, whereas goniotomy is the treatment of choice in clear corneas. In goniotomy, under direct gonioscopic visualization, so here in this picture you can see the cornea is clear. Under direct visualization, an incision is made here an incision is made in the midpoint of trabecular meshwork. In trabecular meshwork, and the aqueous is now drained happily. So, if this fails, again we will go for trabeculotomy and trabeculectomy in repeated failed gonios also. Okay. Now, what if both the surgeries fail? So, if the surgical options fail, we go for glaucoma drainage devices or tube shunt implants, and even if they fail, we will go for ciliary body ablative procedures or cyclodestructive procedures to relieve the symptoms. Follow up, monitor IOP and corneal diameter for long term, and amblyopia and refractive errors are to be managed aggressively because they are children. There is high chance of amblyopia. I also told you that there is high chance of anisometropic amblyopia because of this increased axial length and myopia. So, you have to monitor, follow up the case very regularly. Now, coming to the DDs, here there is cloudy cornea, right. So, the cloudy cornea, we know there is something called stumped classification. S stands for sclerocornea, T stands for tears in the descemetes. Here we see Habstri and congenital glaucoma. Otherwise, I told you the vertically oriented tears are seen in birth traumas. And U stands for ulcers, which could be because of bacterial, neurotrophic, HSV ulcers, anything. There also you see a cloudy cornea. M for metabolic storage disorders, mucopolysaccharidosis. P for posterior corneal defects like Peters or posterior keratoconus. E for endothelial dystrophies, and D for dermoids. Now, those are the DDs for a cloudy cornea. We also see large corneas and ophthalmus in these cases, right. For the large cornea, you can the DDs are simple megalocornea, and for the ophthalmus, the large eyes are seen in high myopes, right. So, that could be a DD. And for the epiphora, the DDs are NLD obstruction, CNLDO, which is commonly seen in infants, congenital nasolacrimal duct obstruction. Then conjunctivitis cases also you have epiphora or watering and uveitis. Now, photophobia. For photophobia, this can occur in conjunctivitis, iritis, trauma and inflammatory conditions. For the optic nerve cupping, the common DDs are pertaining to children, optic nerve coloboma, atrophy, hypoplasia, optic nerve pit, optic nerve malformations, and it could be a physiological cupping also. Keep that in mind. So, that is all about congenital glaucoma, and a very big thank you for watching.